Hello, 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 everyone. Today we are talking about respiratory disorders, and for this morning, this afternoon, this evening, whenever you happen to be listening to this, I will be concentrating on upper respiratory disorders. This is upper respiratory disorders. So, the outcomes for this class are: we will apply the pathophysiology of the upper respiratory tract to patients presenting with upper airway disorders. Now, we've just talked about tracheostomies, and we've talked about suctioning and how to care for these respiratory patients. So I thought it only fitting that we start with the upper respiratory disorders. We will identify the importance of performing a complete health history and assessment. Always, right? Because we need a complete health history, because with upper respiratory disorders, there's lots of things that are involved there. Could be allergies, could be asthma, could be bronchitis. We don't know. And we also need an assessment. We have to know how do these lungs sound? Are they short of breath? We need to know all of this very important information. Determine possible complications associated with upper airway disorders. And we need to determine this, again, because of what we just discussed, which was tracheostomies and suctioning with or without a trach. Because with an upper airway disorder, if there is a foreign body or a mucus plug or some edema and they can't get those secretions up, then we have to do it for them. Identify the clinical manifestations of upper respiratory infections. What do these infections look like? What are these patients going to look like? What are their complaints going to be? How are they going to present clinically? What are their symptoms? And then we need to develop nursing interventions for patients with upper respiratory disorders, because we are nurses and that's what we do. We develop nursing interventions and then we implement those interventions. So, the respiratory system is a complex system that is divided into the upper and lower respiratory systems. So again, for our purposes right now, we are just focusing on the upper respiratory area, the upper respiratory system. So the air is going to enter into the respiratory system through the nose or the mouth, and then it's going to travel to the lungs, where respiration, now please remember, respiration is the exchange of oxygen and carbon dioxide between the outside air and the lungs. And this occurs at the alveoli level. So we're not talking about ventilation where we take the air into the body, right? This is respiration, and respiration occurs at the alveoli level. The major function of the respiratory system is to supply oxygen and to remove carbon dioxide from the body. So therefore, the nurse should complete a thorough assessment, including inspection, auscultation, percussion, and palpation, to identify any dysfunctions, right? Of course, we want to look. Is both sides of the chest rising and falling at the same time? Auscultation. What do these lungs sound like? Are there abnormal sounds? Are there abnormal sounds throughout, or only in the upper lobes, the lower lobes? Percussion. Percussion is done on the back of the body, on the back. And then palpation to identify any dysfunctions. So, functions of the respiratory system. There are the major functions of the respiratory system are to perform the functions of ventilation and then respiration. So ventilation is taking the air into the body, whether it's through the nose, through the mouth, or through a trach. That is ventilation. Respiration, as we said, occurs at the alveoli level. So ventilation will occur as the air moves into and out of the respiratory system through the act of inspiration and exhalation. That is ventilation. So during ventilation, the structures of the respiratory system filter and humidify the air entering the system, right? The structures in our body filter the air and then humidify it. And this is why it is so important that when we are giving someone supplemental oxygen, that it's very drying, because it's pure oxygen coming into the body. That is why they may need humidification. But with us, we do it ourselves. The process of respiration occurs as oxygen and carbon dioxide are exchanged at the level of the alveoli. At the level of the alveoli is where respiration occurs. So, after respiration occurs, the circulatory system is responsible for transporting the oxygenated blood to the tissues of the body, and we call this perfusion. So, in addition to the process of respiration and ventilation, the respiratory system is responsible for the following things. Acid-base balance, and we've spoken about this, right? We've spoken about it in respiratory skills. And that is the exchange of carbon dioxide for oxygen in the lungs, and the renal system plays a part, and the renal secretion of bicarbonate maintain the body's pH between that norm of 7.35 and 7.45, because remember, we have said below 7.35, then the body becomes acidotic, which is a danger, a very great danger. And then 7.45, if we go above 7.45, then we are looking at alkalosis, which is also a danger if the pH goes too high. So not as much of a danger as acidosis, but still a danger. And then there is speech. The movement of air through the vocal cords allows vocalization of words. And this is why, if at all possible, a surgeon will insert the trach below the vocal cords. He will try and maintain and leave the vocal cords intact. There is the sense of smell. The movement of air through the nose allows an individual to smell odors in the environment, right? And this is very important. And then there is a fluid balance, because water is excreted as water vapor through the exhalation process. Believe it or not, during any given day, water and fluid is lost simply as we breathe. And these are the major structures of the upper and lower respiratory system. But for our purposes right now, we are only functioning on the upper respiratory system. So we need to know what we're talking about. We need to know what we're what we're looking at. So we need to know the anatomy of the respiratory system. I am not going to spend a lot of time on this, because you guys have had Anatomy 1 and Anatomy 2. So this will just be a brief overview, let's say. And if you need any more help, or if you need a bigger review, I will leave that to you. If you do need help though, please reach out. So we're going to follow the path of air through this system. So air is going to travel through the upper respiratory system to the lower respiratory system. Oxygen will enter the respiratory system through the nose or through the mouth. And within the nasal cavity are 3 turbinates. These structures are made of bone, and they are covered with cilia. And the cilia is what filters the air, filters the oxygen. So once the air passes through the turbinates, it enters the pharynx. So the pharynx now is divided into the nasopharynx, the oropharynx, and the laryngopharynx. The laryngopharynx, starts at the base of the tongue and continues to the larynx. Once the air leaves the larynx, it enters the lower respiratory system via the trachea. And the trachea divides into the right and left main bronchi. Once air enters the right or left main bronchus, it travels to the lobar bronchi. once the air gets to the lobar bronchi, it will enter the bronchioles, and air will travel through the respiratory bronchioles to the alveolar ducts, both of which are lined with alveoli, to the alveolar sacs, which are clusters of alveoli, and this is where respiration occurs. And this is what you see. You see the bronchiole, and then you see the alveolar sacs, the little capillaries on the alveolar sacs, and then you can see the exchange. Okay, so now that we know how everything works, and we've talked about respiration and ventilation, let's talk about some disorders. So the first one I want to talk about is rhinitis. Rhinitis is a fancy way of saying that the mucous membranes in the nose are irritated and swollen. And there are two common types of rhinitis. One is the common cold, and then the second is seasonal allergies. And these problems, these common problems, affect about 20% of the population. And they can impact your quality of life, causing headaches, fatigue, sleep disturbances, and congestive impairment because everything is swollen, everything is edematous, makes it hard to breathe. But it's hard to breathe, sometimes it's hard to sleep, and then you're tired, you have a headache. So it is all encompassing. Adequate and appropriate management of rhinitis impacts management of asthma, sinusitis, and sleep apnea, which are possible comorbidities. So, rhinitis can result in widespread morbidity with significant impact, significant financial impact, because let's think about this. You don't feel well, so you're going to go to the doctor. And so now, and there may be prescriptions, there may be over-the-counter meds that you can take, but there are medical costs. Then you don't feel well, so there is lost work days. So you are home from work, you are not feeling well, and your boss may be upset with you and your productivity. So rhinitis can be classified as allergic or non-allergic, and it can also be classified as acute or chronic. About 30 to 60 million American adults and children experience allergic rhinitis, and we know this, seasonal allergies. Allergic rhinitis is categorized as perennial or seasonal, and it is seen in people with allergies to plant pollen, animal dander, or dust. So non-allergic rhinitis presents similarly to allergic rhinitis, but does not involve the immune system, right? So allergic rhinitis, remember it when we were talking about allergic disorders and all of that inflammation and all of that symptomology, it involves the immune system, right? So non-allergic rhinitis will present similarly, but it will not involve the immune system. The most common example of non-allergic rhinitis is the common cold, caused by a variety of viruses, because we know colds, we can't cure them, we just manage the symptoms, and it is usually self-limiting unless a bacterial infection occurs simultaneously, which can happen. You have a cold, you know it's a cold, you feel crappy, so you're managing the symptomology, you're taking your over-the-counter medications, and you're drinking your tea, and you're getting your rest, and you're drinking your fluids, and all of a sudden that cough becomes productive, or that nasal drainage becomes discolored, and then we say that you started out with a common cold, but somewhere along the way you also picked up a bacterial infection. So acute rhinitis can last 1 to 3 weeks. Acute rhinitis can last 1 to 3 weeks. And it can be non-allergic, or it can be an allergic reaction. Remember, when we were talking about allergic disorders, we had no idea where the exposure was coming from. So we couldn't really ascertain the symptomology. Here we can. We know that it will last 1 to 3 weeks. Chronic rhinitis may last up to 12 weeks. And this is the lingering cold. This is the cold or the stuffy nose that will not go away, the irritating cough that will not go away. It seems to last forever. And then when you're talking to someone, you say, oh, I've had this for weeks, and oh my gosh, it's been so many weeks, I probably had it for months now. And so that may be a chronic rhinitis. So the pathophysiology of this, how does this happen? Well, there is an inflammation and irritation of the mucous membranes that are lining the nose. It can also affect the eyes, the throat, the ears. Allergic rhinitis occurs in response to exposure, of course, to allergens found in the environment, medication, foods, or occupational irritants. And again, think back to when we were talking about allergic disorders. Foods that may induce allergic rhinitis include peanuts, cow's milk, nuts, eggs, and wheat. And again, all of these are common things that people are allergic to. Mechanical obstructions within the nose or sinuses, such as polyps, if someone has a nasal septal deviation, hypertrophy of the nasal turbinate, or sinus tumors may also result in the development of rhinitis, because all of this is going to irritate and then inflame the mucous membranes of the nose. And so this is what we will see. On the left, as you're looking at it, you can see the frontal sinus and then the maxillary sinus. So the frontal sinus is just above the eyebrows, near the bridge of the nose. And then the maxillary sinus is where we know that our sinus cavities are. So you can see that the infected sinuses on the right, you can see that yellowish, that would be the nasal drainage, the discolored nasal drainage. So, ladies and gentlemen, what are we going to see with these clients, with these patients? What are they going to say? What are they going to complain about? So symptoms will include nasal itching, sneezing, nasal congestion, and rhinorrhea. Rhinorrhea is a fancy name for a runny nose, which is excessive nasal drainage. And the question will always come when we're talking about this, and that is, my nasal passages are so stuffy. They're so swollen. I can't breathe. I can't breathe through my nose, but yet I have all of this drainage coming out of my nose. And that is because the nasal drainage is able to, it's the nasal passages, the tissue that is swollen, and that has actually nothing to do with the nasal drainage escaping. So in chronic rhinitis, symptoms will last 12 weeks or longer, with discolored nasal drainage and radiographical evidence of these fluid levels within the sinuses. So when we look at the sinuses on X-ray, we will see that they are swollen, and then we will be able to see those fluid pockets there. And yes, in chronic rhinitis, symptoms will last for 12 weeks or longer, which is 3 months. And and so that is just managing the symptoms and trying to make the patient as comfortable as we can. So management and diagnosis. Diagnosis is based on history and on the patient's symptoms. What are they saying? What are they complaining about? What is their history? Does this happen to them every year? Does it happen at the same time every year? So then that would be allergic rhinitis. So fall, spring is when you will see this. Treatment and management is dependent on the cause. And again, we are just really treating the symptoms and making the patient comfortable. Obtaining a history on the onset of symptoms that focuses on the pattern, seasonal aspects, environmental exposures to allergens in the home or at work, and then precipitating factors that are serving as the basis for determining treatment. So again, we need to look at the history. Does this happen every year? Is this the first time? Are you doing anything different? Have you moved? Are you working at a new place of employment? What is going on with you? And then, when did these symptoms start? And how can we make you comfortable? So if rhinitis is caused by a viral cause, medication to relieve symptoms may be prescribed. And as you know, medications, again, are going to focus on the symptoms, because if it is a virus, we have no medications for virus, right? The virus just has to run its course. All we can do is treat the symptoms, relieve the symptoms. So, in allergic rhinitis, allergy testing may be indicated, followed by a desensitizing regimen, and that is because if we think back to when we were talking about allergies and allergic disorders, in order to control this allergic rhinitis, we need to know what we're allergic to. We need to know what the triggers are. So if you think back, we may have to do the prick test, and then the desensitizing regimen is when you are exposed in small amounts to whatever your trigger is every day in order to desensitize the body. I don't subscribe to this thought. I know that there is literature out there, but I also know that the more that you're exposed to something that you're allergic to, the potential is there for that reaction to become more severe every time. So I don't recommend doing this unless you are doing it with a physician. There may be a referral to an ear, nose, and throat specialist for assessment of nasal polyps, nasal septal deviation, and hypertrophy of the nasal turbinate or sinus tumors. So by going to an ear, nose, and throat specialist, they can do the appropriate testing, the appropriate assessment to find out what may be going on with you. So additional diagnostic testing may include pulmonary function testing, because we want to know if these lungs are affected, what's going on with that. You may have asthma, or you may have obstructive sleep apnea, and that will need to be addressed by a pulmonary physician. So medications. What medications are we going to use for this? So pharmacological management in allergic and non-allergic rhinitis is aimed at symptom relief. We just want to, excuse me, I myself have rhinitis. We want to manage the symptoms. We're looking for whatever will make the patient comfortable. So oral antihistamines, nasal spray antihistamines, and corticosteroids and decongestant medications can assist in relief of symptoms. And many of these are over-the-counter medications that doctor will recommend. But prescription and over-the-counter medications are the most common treatment of symptoms of sneezing, rhinorrhea, and again, rhinorrhea is a fancy name for a runny nose, and pruritus. Pruritus is itching. Sedation, performance impairment, and anticholinergic effects such as a dry mouth and eyes, constipation, and increased heart rate are common side effects of first-generation antihistamines. And I myself have been taking an over-the-counter antihistamine, and I will just share with you that it is making me incredibly dry. I want to drink all day long, and usually I am not a drinker. Well, I am a drinker, but I'm not a drinker of, water or anything like that. And I prefer soda, tea, coffee, and it does make you so dry. So please, when you're talking to your patients and you're recommending these medications, you will let them know that one of the side effects is this dryness. Second generation over-the-counter antihistamines such as Claritin have less or no tendency to cause sedation, but you will have the same side effects: the dryness of the mucous membranes, constipation, increased heart rate. All of that will remain the same, but It will not cause sedation. They will not get sleepy. Intranasal corticosteroids is the most effective treatment of allergic rhinitis and symptoms when used on a regular basis. There is no systemic effect from the use of this corticosteroid because remember, when people take a steroid, there's the increased heart rate, there's the weight gain, there's you get that burst of energy because it is a systemic effect. But when you use an intranasal corticosteroid, you get none of those systemic effects. None. And intranasal sprays that contain antihistamines can result in systemic antihistamine effects. So, let's look at this. Corticosteroids, intranasally, no systemic effect. Listen up, no systemic effect. Intranasal sprays that contain antihistamines will give the patient a systemic antihistamine effect. Understand? Saline nasal sprays can be effective in relieving symptoms such as nasal congestion and sinus pressure and their related effects. So if the client says, I don't want to use an antihistamine because I don't like the way it makes me feel and because they will get those systemic effects. So please, is there something that I can use that will relieve my symptoms? Then doctor or you could recommend a saline nasal spray. Saline nasal sprays have no negative effects. Listen up, listen up, listen up. Saline nasal sprays have no negative effects, as can be seen with antihistamines or decongestants. So it is a more natural approach. Decongestant medications can reduce nasal congestion and obstruction. And then side effects of these drugs include insomnia. They can make you irritable. You can experience heart palpitations. So if you are looking for something that will have no negative effects, listen up. It will be a saline nasal spray that you can recommend as a nursing person, nursing professional, or doctor can recommend. Use of these drugs should be avoided unless nasal antihistamines and corticosteroids have been ineffective. They should also be avoided in patients with a history of cardiac disease, hypertension, glaucoma, cerebrovascular disease, and cardiac dysrhythmias due to vasoconstriction. So, that is why it is so important to obtain the history of your patient, because if there are underlying conditions, cardiac disease, hypertension, cerebrovascular disease, a cardiac arrhythmia, glaucoma, these medications will have an effect. So, they should not be recommended. Decongestant nasal sprays, such as oxymetazoline, which is Afrin, should only be used for a few days at a time, as overuse may cause rebound congestion. Rebound congestion is severe congestion. This is when you use the nasal spray and then you feel wonderful. Everything is open, you can breathe, and then as soon as you start getting that stuffy nose feeling, you want to use it again. Nope, should not be recommended, should not be done. And this is something that is not to be used on a daily basis. If it is used on a daily basis, it needs to be structured so that it is only used for a few days at a time, 3 days max. Actually, my preference is 2 days, but that's just my preference. Because this rebound congestion, this severe congestion can occur. If infectious rhinitis is present, administration of antibiotics is required with selection of the antibiotic based on the patient's history, the allergy, and then the severity of the infection. So again, decongestant nasal sprays such as Afrin should be used on a limited time basis because it can cause this rebound severe congestion. And this is why, if the rhinitis is infectious, the antibiotic is going to handle the infection, and it will help with this congestion, and the patient will feel better without using the nasal spray. And again, that is why we need the patient history, what the patient may be allergic to that is causing this rhinitis, and then the severity of the infection. What are they complaining about? What are we seeing? What are the symptoms? What are these clinical manifestations? So, nursing management. Symptoms of rhinitis are due to the irritation and inflammation of the mucous membranes of the nose, resulting in nasal congestion, sneezing, and nasal drainage. This is, I don't want to sound, but it is. It's all in the head. So when we're looking at this rhinitis, it is all in the head. Some nursing diagnoses: alteration in comfort, related to the sinus inflammation. These nasal passages are going to be very inflamed, very irritated. Your patient is going to be very uncomfortable because they cannot breathe. They can't breathe through their nose. Knowledge deficit related to medication regimen. And again, this is when you are going to educate them about the decongestant nasal sprays, such as Afrin. You are not going to use it more than once a day, and you are not going to use it for more than a few days in succession. If they're using over-the-counter medications, we have to talk about the sedation effects. We have to talk about the increased heart rate. We have to talk about irritability. And if they are looking for something that is more natural, that is going to relieve the symptom, it will be a saline nasal spray. Listen up. Risk for infection related to inadequate primary defenses. And so this is when something occurs. Maybe it's allergic rhinitis, and somewhere along the way we pick up a head cold. So now we're also treating the rhinitis, and then we may also be treating a viral infection. And again, if it is a viral infection, it is just going to be over-the-counter medications to alleviate the symptoms. If it is a bacterial infection, they will need an antibiotic. Nursing interventions. Assessment. We are going to assess because we are nurses, and that is what we do. We are going to assess vital signs. So temperature elevation may indicate the presence of infection. This we know, right? The first thing that we look for when we suspect infection is, do they have a fever? Elevation in heart rate and blood pressure may be related to the medication that is used to treat these symptoms. So if they're taking an over-the-counter medication, then their heart rate and their blood pressure could be elevated, right? Because that's one of the side effects, but not temperature. Temperature indicates infection. Nasal drainage. Nasal drainage should be thin and clear. When it becomes discolored, yellow or green, that will indicate an infection. So when you are doing your patient education and you're telling your patient, monitor your nasal drainage, and when it starts to become discolored, you need to reach out to us again. Administer medications as prescribed, oral or nasal antihistamines, oral or nasal corticosteroids, decongestants, antibiotics. These medications are used to control symptoms of excessive drainage, inflammation, nasal congestion. Antibiotics are used to treat infection. They're used to treat the infection only. If this is something that is viral, you can take an antibiotic until the cows come home. It is not going to make a difference. Diphenhydramine is the first generation antihistamine. Guaifenesin is a common decongestant. And fluticasone is the preferred corticosteroid nasal spray. Please know these medications. Listen up, listen up, listen up. Please know these medications. You need to know the first generation. You need to know what is the common decongestant, and you will need to know what the preferred corticosteroid nasal spray is. Take note. Patient education, you're teaching. Of course, we are going to use the appropriate use of medications, and you are going to speak to your patient about this. You are going to say Avoid the nasal decongestant use for greater than 2 to 3 days at a time because of this rebound congestion. Instruct patient to complete the antibiotic therapy as prescribed to avoid a super infection. Most people, they will take the antibiotic until they start to feel better, and then they're like, I don't think I need this anymore. But no, they need to finish the course of the antibiotic. Take note. They need to avoid their known allergens or their triggers if they are aware of them, and prevent the spread of infections. So if they suspect that this is viral, or if we know that it is bacterial and they're taking an antibiotic, they know that they're infected. So hand washing, which we're all doing now anyway, social distancing, don't go near anybody. And we're all doing this anyway because of COVID, but you want to talk to your patient about this and just reinforce these techniques. And then how do we know? How do we know if we've done a good job with talking to our patient? How do we know if they're getting better? We are going to evaluate their relief of their symptoms. So relief of symptoms is the expected outcome for the patient with rhinitis. If their symptoms are relieved, if they're more comfortable, if it's an infectious rhinitis and the antibiotic is working, then we have the expected outcome. If it is a viral rhinitis or an allergic rhinitis, and if they're comfortable, if their symptoms are managed, then we have done a good job. So, ladies and gentlemen, here we are, rhinosinusitis. In 2007, the American Academy of Otolaryngology, let's try saying that one, Head and Neck Surgery Foundation practice guidelines identified that rhinosinusitis is the preferred term when referring to sinusitis because it is a more comprehensive term, because it doesn't always involve the sinus cavities. So, according to the Academy, 1 in 7 Americans is affected, resulting in 31 million people diagnosed every year. So we know that it is pretty common, right? 31 million people. Healthcare-related costs are estimated at $5 billion annually. That is a lot of aspirin nasal spray. That is a lot of Claritin. That's a lot of Benadryl. That is a lot of over-the-counter products flying off of those shelves. So these costs are also related to acute care and emergency department visits, surgical procedures on the paranasal sinuses. So classification of rhinosinusitis is based upon duration of symptoms and includes acute, subacute, and chronic. So now we have 3 classifications, right? Acute, subacute, and chronic. With sinusitis, we had acute and chronic. So acute rhinosinusitis is defined as lasting less than 4 weeks. Less than 4 weeks. So you get it, you suffer for a couple of weeks, the better part of a month, and then it's gone. However, subacute will last 4 to 12 weeks. Subacute is lasting 4 to 12 weeks duration, which is a month to 3 months. So this is something, if it's allergy related, that they may be walking around with from spring into summer. Chronic rhinosinusitis is more than 12 weeks and may include exacerbations of symptoms. So this is something that they have all year long, and it is worse at other times. Say they may have rhinosinusitis all year round, but it may be worse during allergy season. Acute rhinosinusitis is further classified by etiology as either acute bacterial rhinosinusitis or viral rhinosinusitis. So, and we know that if it is bacterial, it is going to involve what? An antibiotic. And if it is viral, we are just going to be managing the symptoms. So, viral upper respiratory infections that spread to the paranasal sinuses are the cause of most acute rhinosinusitis, which can then lead to bacterial infections, right? So I start out with, something that is an upper respiratory infection, and it starts out as a virus. I pick something up somewhere, and then I can't shake it the longer it's with me, and now I have a bacterial infection. A deviated nasal septum, trauma to the nose, or tumors will interfere with nasal drainage and contribute to the development of acute rhinosinusitis, right? Because those sinus passages cannot drain. So if the sinus passages cannot drain and all of that nasal drainage accumulates in those passages, it's very dark in those sinuses, it's very wet and moist in those sinuses. So then what is going to develop? Well, bacteria, right? This we know. So annually in the United States, there are about 20 million cases of acute bacterial rhinosinusitis with a resulting cost of $3 billion in healthcare. So we know that this is pretty common, right? You get a head cold, you get a sinus infection, and you go to the doctor, and you're getting an antibiotic. So healthcare needs for treatment of ABRS, acute bacterial rhinosinusitis, include primary care office visits, diagnostic testing, then the antibiotics, and then any additional prescription medications that we are going to use for symptom management, right? So this is pretty costly, because you got to go to the office, you got to see the doctor. He may want to do some testing, maybe an x-ray of the sinus passages, looking at your symptomology. If you're running a fever, if your nasal drainage is discolored, you may need an antibiotic. And then there may be other things over the counter that you may use to control your symptoms and keep you comfortable. So the socioeconomic impact through indirect costs is also significant, because you are losing work days and there is a decrease in your productivity at work because you feel like crap, you don't want to go to work, and so your boss is unhappy with you, loss of work days, loss of productivity, loss of money in your paycheck. Acute rhinosinusitis can progress to chronic rhinosinusitis, CRS, which is one of the most common chronic diseases, right? These are the people that always seem to have that chronic cough. They're always clearing their throat. They chronically have a runny nose. The nasal drainage is clear, but they're always blowing their nose. They're sniffling. These are those people. And 14% to 16%, of the United States population is affected. So this is pretty common. It is more common in females, and the presence of nasal polyps is seen in 19 to 36% of patients. So in order to diagnose these nasal polyps, doctor sometimes has to go up with a very thin scope and take a look around, see what's going on in those nasal passages, and then we will see the nasal polyps. This results in significant healthcare costs again, because of repeated visits to the primary care physician, and then again the use of prescription medications. So this can be pretty costly. And it will also have an impact on quality of life due to symptoms and then impaired physical functioning, because you feel like crap. You never really feel well. And then even though you may feel well, or what is your baseline well, during those times where you have an exacerbation, maybe in the spring or in the fall, you're going to feel worse. So rhinosinusitis is infection and inflammation of the paranasal sinuses, which are four paired air-filled spaces that surround the nasal cavity. And if you look back to the picture in the PowerPoint, you will see that they are the areas above the bridge of the nose, over the eyebrows, and then below the eyes in the cheekbones by the bridge of the nose where the sinus cavities are. So inflammation of the nasal passages causes vasodilation, increased blood flow, and vascular permeability, reducing the size of the nasal passages. Everything is inflamed and angry in there, but and this is where we get that stuffy nose feeling. We get that stuffy nose feeling, and again, my nose is so stuffy, I feel like I can't breathe properly through my nose, but yet my nose is running, and I feel the need to blow it. So nasal congestion occurs as a result of swelling of the nasal turbinates, which are the bony structures along the nasal passages that help in maintaining moisture and trapping airborne particles, right? So, and again, this is why not to get off topic, but this is why patients who are using supplemental oxygen, they need humidification to keep those nasal passages moist, because pure oxygen is a lot drier than room air. And so these bony structures along the nasal passages that become inflamed or swollen, this can result in obstruction of nasal airflow. So again, you can see the healthy sinuses as you're looking at this picture. You can see the healthy sinuses on the left-hand side. You can see the frontal sinus and then the maxillary sinuses all along the bridge of the nose. And then on the other side with the rhinosinusitis, you can see the inflammation and the mucus. And then you can see that greenish discoloration that represents the infection. So, what are we going to see? What are we going to say? What are we going to hear from our patients? Diagnosis is by the presence of 3 symptoms. So, rhinosinusitis is going to be diagnosed by the presence of 3 symptoms, and that is purulent nasal discharge, that greenish, yellowish color nasal discharge when they blow their nose, the nasal obstruction where they feel so stuffy and they feel so congested that they're not breathing properly, and then one of the hallmark signs, and this is the facial pain, which they will describe as a headache along the forehead, over the bridge of the nose, and then a headache or facial pain where the sinus cavities are. So it'll be facial pain, pressure, or fullness. So when doctor or nurse is doing the examination and they touch the face, they will touch that face where the sinus cavities are, and it will be painful to the patient. Nasal secretions will be colored or cloudy in nature, which is going to represent the infection. Nasal obstruction will be spoken about as congestion. I feel congested, I feel stuffy, I feel like I have, like a bunch of stuff up there. I can't take a big breath in my nose. Onset of these symptoms in relation to the development of upper respiratory symptoms indicates acute bacterial rhinosinusitis. So, additional symptoms. Listen up. Additional symptoms to the presence of the 3 symptoms, which are purulent nasal drainage, nasal obstruction, and then the facial pain. These are additional symptoms. They will include fatigue. Your patient is going to say, I am tired. I feel tired. They may have a fever. They may have maxillary dental pain because those sinuses, the way those passages are, it may cause pressure in the face and extending to the gums. So they may interpret that as dental pain. They may have a cough. New onset of headache may affect their ears. They may not be hearing properly. They may feel as though their ears are clogged. So, additional symptoms 2. The 3 symptoms are fatigue, fever, maxillary dental pain, there may be a cough, new onset of headache, ear fullness, or ear pressure. Please take note. Nasal purulent drainage may also be noted on the posterior pharynx. So at the doctor's examination or the NP's examination, she may ask you to open your mouth, stick out your tongue, and on the posterior pharynx, she may see little pockets of purulent discharge. So indications of extra sinus involvement include signs of neck stiffness, which may also lead us to think possible meningitis, orbital protrusion, cellulitis of the face or the orbit, abnormal eye movement, because all of this has to do with the facial structure. Symptoms that last for more than 10 days without improvement indicate acute rhinosinusitis. Listen up. Listen up. Listen up. If your patient relates that their symptoms are lasting for more than 10 days without feeling any better, they are classified as acute. Please take note. So management and diagnosis is primarily based on the physical examination. The physical examination. We want to look at the nose. We want to look in the ears. We want to look at the face. We want to touch the face for that facial pain. So medical management will start with the completion of a history and physical examination focusing on the ears, the nose, the throat, the teeth, the sinuses, and the chest. Why the chest? Because the sinuses may drain, and then we are possibly looking at an upper respiratory infection. So it is going to pass from the sinuses into the upper chest area for an upper respiratory infection. So we have to do a complete physical examination. During the physical examination, the provider is looking for signs of inflammation. He's looking for tenderness, that facial tenderness, firmness, or redness. Light palpation or percussion of the sinuses using the index finger is due to evaluate the presence of pain in those sinus cavities. We are also going to look at vital signs. So vital sign assessment also needs to be done because we have to know if they have a fever. Do they have a temperature elevation? Because why? Well, because the first sign of infection is usually an elevated temperature, right? Diagnostic testing may include radiographical images of the sinuses. Maybe we're going to do a CT. Maybe we're going to do an MRI. If their clinical diagnosis does not tell me anything. So they may be sitting there, they may have vague symptoms, and I've done my physical assessment, I've done my health history, I've examined everything, we've had a conversation. They may be telling me that they have a fever, but the rest of their vital signs are within the norm. So now I need to move on to diagnostic testing. On radiographic studies, fluid, thickening of the mucus lining of the sinuses, and the presence of polyps, opacities, or foreign objects may be found, indicating rhinosinusitis. Right? So how am I going to make my diagnosis? Well, I'm going to do my history. I'm going to do my assessment, my physical assessment. I'm going to look at the nose. I'm going to look in the throat. I'm going to look up the nose. I'm going to look in the ears. And then I'm going to look at the vital signs. Do they have a fever? Do they not have a fever? And then if I can't determine anything, then I'm going to move on to diagnostic testing. And then this may give me the diagnosis of rhinosinusitis. So again, the focus of treatment is going to be based upon the etiology. Is this chronic? Is this acute? Is this subacute? What is it? Treatment goals will include treating the infection if present, so they are going to need an antibiotic. Pain relief, Tylenol, maybe warm compresses to the face, maybe positioning where they're not lying down, and the head may hurt a little, the headache may be a little worse if they're lying down. And then reducing that nasal inflammation. In a bacterial infection, antibiotic therapy is going to be required. Caution must be taken to prevent antibiotic use in non-bacterial illnesses, such as a viral rhinosinusitis, to prevent development of antibiotic resistance. Because now, and we've all been this patient, we've all heard about this patient, we've all met this patient, where you just feel crappy. You may have a fever, you have a stuffy nose, you have a sore throat, your sinuses are full, you cannot breathe, your nose is stuffy, and you go to the doctor. The last thing you want to hear is, you know what, this is a virus and it's just going to have to run its course. And then what? Then that makes us angry, right? Just give me something to feel better. Give me something to make me feel better. I need an antibiotic. No, you don't, because it's viral. You can take an antibiotic until the cows come home, and it is not going to make a difference if this is a viral rhinosinusitis. It is managing the symptoms, and that's about all we can do. Normal saline irrigation has local effects that can reduce the symptoms in acute rhinosinusitis. Me, myself, I do not practice this, and I have never recommended it, but I do know that some people find it helpful. And this is a neti pot. This is something that that your client or your patient may use to irrigate those nasal sinus passages. Again, myself, I have not used one. I have never recommended the use of a neti pot. However, it is noted that normal saline irrigation is beneficial in the removal of infections, debris, bacteria, allergens, and then those inflammatory mediators. It will also decrease edema of the nasal mucosa and the viscosity of nasal secretions. And again, I have not used this. I have not recommended it. I have never instructed on it, so I cannot address this. Delay in initiating antibiotic therapy may be indicated if the patient presents with symptoms of non-severe illness, which is a temperature less than 101, or with mild pain. So if it really doesn't warrant it, even though they may be feeling crappy and they have all this symptomology going on, and even though I know that an antibiotic may be warranted, then the question becomes, do they need the antibiotic now? Do they need the antibiotic now? So then we have to go back to, have these symptoms been present for longer than 10 days without improvement? So then treatment will be focused on symptom management and then following up. We want to know what is happening over the course of these 10 days. After 7 days, if the patient fails to improve or worsens any time within that 7-day period, then antibiotics will be prescribed. So amoxicillin clavulante is the first line therapy for most patients because it is efficient, it is safe, it has a narrow biological spectrum, which means that it is very, very effective with rhinosinusitis, and it has a low cost factor. So it's efficient, it's safe to use, we know it's going to work, and it is not going to cost a lot of money to the patients. However, in patients with penicillin allergies, then we will look at Bactrim, Septra, the macrolides, the Bioxin, and azithromycin. We will go there. But the amoxicillin Clavulante is the first line therapy. Listen up, listen up, listen up, and please take note. This medication is effective, it's efficient, it is safe to use, and it has a very low cost to the patient. It is the first line therapy. In patients who fail to respond within 48 to 72 hours of treatment or have persistent symptoms, then we're going to go to the second line antibiotics. Antipyretics and analgesics are used as needed to control temperature and to control pain. Use of intranasal corticosteroids is recommended in patients with a history of allergic rhinitis. Why? Because steroids are going to be used to take down that inflammation, because this is allergic rhinitis, right? We want to take that inflammation down quickly because we don't want the allergic reaction to progress. Do you remember back to allergic disorders, right? We want to treat this inflammation. We want to treat this edema. So listen up, listen up, listen up. Use of intranasal corticosteroids is recommended in patients with a history of allergic rhinitis. Please take note. So, use of a decongestant and normal saline irrigation can be helpful in reducing osteomeatal complex, which are the bony structures around the drainage opening of the sinuses. Obstruction facilitating drainage of the sinuses. So we can use a decongestant and we can use a normal saline irrigation. Again, I never recommended it, but it can be helpful in reducing the draining of the sinuses, Patients with hypertension should use caution when taking oral decongestants. Why? Because they're going to increase their blood pressure because of their action of vasoconstriction to reduce the stuffiness. So it's going to help to reduce the stuffiness, but it's going to raise their blood pressure. It is going to raise their blood pressure. So patients with hypertension, doctor has to be very, very careful when he is talking about recommending a decongestant. Medications typically used for symptomatic relief should be used with caution, including antihistamines that may cause drying of secretions, impairing the mucus drainage. So you don't want to use a medication or an antihistamine that is going to make you so dry that mucus is going to become so dry that it cannot be, that you can't blow your nose or you can't cough it, right? So we just want symptomatic relief somewhere in between there where we can say, I'm feeling a little better, but I'm still able to blow my nose and get rid of this drainage. Topical decongestant sprays, if used more than 3 days, may result in this rebound nasal congestion when discontinued. And we've talked about that before, right? No more than 2 to 3 days and no more than once a day. No more than once a day and no longer than 2 to 3 days. So, acute rhinosinusitis, if left untreated or inadequately treated, meaning I know that I'm sick, I feel like crap, but I'm going to put off going to the doctor because I don't want to sit in the doctor's office, I don't want to wait in the waiting room, I don't have the money for the copay, whatever it is, can lead to several potentially serious complications that include orbital cellulitis because those sinus passages are so full. Orbital abscess, because those passages are so full and not draining. Osteomyelitis, meningitis, sepsis, and then a subdural abscess. All because we took too long or we did not go to the doctor. Orbital cellulitis and orbital abscess can occur from transfer of a sinus infection to the area surrounding the eye. And this is where, and we see it most often in babies and in small children that have head colds, that have sinus infections, that they get that yellowish drainage coming from the tear ducts. And that is because the sinuses are so full that the sinus drainage is spilling out. With chronic sinus infection, bacteria can infect the facial bones, resulting in osteomyelitis, because I didn't go to the doctor. Meningitis and subdural abscess can occur when bacteria pass through the meninges. So the sinuses are so full that, again, there is overflowing, and then it is going to spill out of the sinus cavities. So nursing management, what do we do? What do we do? So we know that symptoms are due to obstruction in the flow of nasal drainage from inflammation of the sinus lining. These symptoms include a combination of the facial pressure, which is a hallmark sign, sense of fullness or pain, or nasal obstruction, which is a hallmark sign, and then the presence of purulent, which is yellow-green nasal drainage. Again, a hallmark sign. Some nursing diagnoses: knowledge deficit related to self-management and symptom management. We need to instruct the patient. We need to offer some patient education on how to manage these symptoms, how to relieve the symptoms, and for your patient to be more comfortable. Risk for infection related to the antibiotic use, right? We want them to use the whole course of the antibiotic. They have to finish the course. You can't just start to feel better and not finish the course of the antibiotic. Insomnia related to the nasal congestion. They're so tired. They may be tired from the fever, and they just want to lay down, take a nap. They're not sleeping well at night because the sinus passages are so full, and they have nasal pressure that they can't sleep well. And acute pain, again, it's that facial pain or that headache related to the nasal congestion. So nursing interventions, what are we going to do? Well, we are going to assess, right? Because we are nurses, we assess and then we reassess, and then after that we go back and reassess again. We are going to look at vital signs. Temperature elevation may indicate the presence of infection. This we know, right? Remember, increased blood pressure may be a side effect of the decongestants. So if their blood pressure is going up, and if they are somebody that already has a history of hypertension, we have to find out if they're taking a decongestant. Maybe they're taking a decongestant over the counter, and they're not aware that it is going to increase their blood pressure. And then we're going to look. We're going to look at the mouth. We're going to look up the nose. We're going to look at the face. Facial pressure, sense of fullness or pain or nasal obstruction, and the presence of that yellow-green nasal discharge indicate impaired nasal drainage, right? We know now that they probably need an antibiotic. Swelling, redness, and pain around the eyes can indicate an abscess or the cellulitis. And then we're going to touch. Palpation of those sinuses is going to be painful, and that will identify the presence of fluid within the sinus cavity, which is giving your patient their pain. So what are we going to do? We are nurses. What are we going to do? We are going to administer medications as doctor orders. Normal saline irrigation if the patient wants and if doctor says it's okay. Decongestants, but again, we have to be very, very careful if they have a history of hypertension. And antibiotics, they have to finish the course. So medications will be used to control symptoms of nasal congestion, excessive drainage, and the inflammation, and then antibiotics are used to treat the bacterial infection. So patient education. We need to instruct these patients, instruct these clients about when to reach out to us, what they will look for, what they will see. Symptoms to report to us are if they did not have a temperature before, but they have a temperature now. Increase in the pain, increase in their change of level of consciousness, redness or edema around the face and the eyes, which can indicate the complication of rhinosinusitis, which is cellulitis or an abscess, right? Instruct patient on correct medication usage. So they need to limit that use of the decongestant nasal spray to less than 4 days. I like less than 3 days, no more than 2 to 3 days, and only once daily to avoid that rebound decongestion. And then, if so warranted, teach them the proper use of the normal saline nasal rinse, which will help removing the debris and the excess mucus. I myself cannot speak to that because I have never instructed on it. So how do we know? How do we know that your patient is improving? How do we know that we've done a very good job in taking care of this patient? So with treatment, patients decrease in and resolution of symptoms such as nasal congestion and drainage. They're able to blow their nose. They're able to get rid of that nasal drainage. They are no longer feeling congested. They no longer have a headache. They no longer have that facial pressure or that sense of fullness in their sinus cavities. Resolution of a bacterial infection is managed through antibiotics. Did they finish the course? Did they finish the course? And it is important that the patient report unresolved symptoms to avoid those more serious complications of orbital cellulitis, osteomyelitis, or chronic sinus infection. So again, follow-up care is very important with these patients because we want to know that the symptoms are either resolving, decreasing. If they are increasing, then we need to continue our treatment plan or maybe change the treatment plan. So, obstructive sleep apnea. Obstructive sleep apnea. This is a condition where the upper airway is obstructed during sleep. And this causes a narrowing of one or more sites of the upper airway, resulting in intermittent breathing patterns. So, patient falls asleep, those upper airways become narrow, and then they do not breathe well. They do not breathe consistently. And this is present in 2 to 4% of the population. Prevalence is increasing due to increased awareness and recognition, which leads me to believe that it is more present in 2 to 4% of the population. Out of all the people that I know personally, I know at least more than 2 to 4% of just the people that I know have obstructive sleep apnea. So risk factors include the male gender, although I do know some females that also use a CPAP. Risk factors include male gender, obesity, cigarette smokers, alcohol use, age between 40 and 65, and if you go through menopause. Insulin resistance is associated with the severity of obstructive sleep apnea. Insulin resistance, this is that term that I really dislike, and you may be more familiar with the term pre-diabetic. But the pre-diabetic stage is really diagnosed as insulin resistance. So, obstructive sleep apnea is present in a higher prevalence in patients with diabetes, right? So there are increases in the prevalence of the risk factors of obesity, insulin resistance, and diabetes mellitus associated with obstructive sleep apnea. So how does this happen? What is going on? Well, it occurs during sleep as the upper airways narrow or they can collapse, increasing resistance to airflow. So when this happens, if they are not already using a CPAP or a BiPAP, what you will hear is snoring. This narrowing can occur in the retropalatal region, retroglossal region, or in the nose. So with the onset of sleep, the normal work of breathing is unable to overcome this increased resistance in the upper airway, causing collapse. And then again, what you will hear is snoring. So here, this is what you will see. In the normal breathing pattern on the left, you can see that the airway remains open. The air is flowing freely to the lungs. However, with obstructive sleep apnea, you can see where that airway is collapsing and narrowing, and airflow is blocked to the lungs. And you will see this on the right. And so here you can see the retropalatal region and then the retroglossal region. So narrowing of the upper airway increases respiratory pressure and intrathoracic pressure, resulting in decreased minute ventilation and gas exchange. So this has nothing to do, obstructive sleep apnea has nothing to do with respiration. It is all about ventilation, all about ventilation. So because these upper airways are narrowing and sometimes collapsing, there will be periods of apnea. So apnea means that there is no respiration, there is no ventilation. During apnea, there is no tidal volume, no movement of air in or out, and no gas exchange in the alveoli. So what happens is, if left untreated, and if these periods of apnea go on and on and on, what's going to happen? Your patient is going to pass away. They're going to pass away because there's no ventilation, there's no movement of air in or out, and then there is no respiration, no gas exchange in the alveoli. So hypoxemia, which is decreased concentration of oxygen in the blood, and hypercapnia, which is increased concentration of carbon dioxide in the blood, leads to acidosis, right? And what happens with acidosis, the body does not like to be acidotic, and that will lead to respiratory arrest or cardiac arrest. Well, here it is leading to respiratory arrest. So increased sympathetic vasoconstriction actively occurs as a result of the decreased tidal volume and the apnea, right? So the body becomes acidotic, and then respiratory arrest will occur. Clinical manifestations. What are we going to see? What are we going to hear? What does this patient look like? It is characterized by the following symptoms: loud snoring, because those passages are narrow. Witnessed apnea. This is when, the wife is with the husband and he's snoring, and then there is no snoring. And then she looks over and she may not realize that he is not breathing at all. So then what happens is that this patient will start to gasp, and they wake themselves up. They're snoring, they stop snoring, they take a gasp, they're gasping, and then they wake themselves up. And what happens is there's coughing or choking. So spouses will often report patients have disruptive snoring, and then they will witness these periods of apnea. So 15 or more obstructive sleep events per hour are sufficient to make a diagnosis of obstructive sleep apnea. So because of frequent sleep disruptions, patients will complain of excessive daytime sleepiness. They're tired all day long. They do not wake up in the morning feeling refreshed as though they had a very good night's sleep, because they have not had a very good night's sleep. They will fall asleep during quiet times. These are people who are maybe reading something at their desk, or they're doing computer work and they're just so tired during the day that they will fall asleep. These are people who come home at night and they're sitting reading the newspaper, or they're watching the news, and they fall asleep. They have short and repetitive attention lapses where they may become a little forgetful. And then there are people that are so tired, and on their lunch break will go and take an intentional nap because they do not rest well at night. So, diagnostic testing begins with a sleep history, and sometimes not the patient's history. Well, it is the patient's history, but you're not talking to the patient. You may want to talk to the spouse or the significant other who was sleeping in the room with the patient. And so we are going to ask questions regarding the history of snoring, and are they sleepy during the day? A history of obesity, atrial fibrillation, nocturnal dysrhythmias, type 2 diabetes, heart failure, and pulmonary hypertension all will place patients at a higher risk for this obstructive sleep apnea. So, doctor will do a polysomnography, which is a sleep study, and this can be conducted in an overnight lab situation, or sometimes now they can use a portable home device at home. They hook themselves up at home and they sleep as they usually do in their bed where they're more comfortable, and then they return the machine, and then looking at the readings on the machine, diagnosis can be made. So treatment, now that we know that they have it, how do we treat it? Treatment will require multiple interventions and active participation of the patient. So this means the patient has to actually follow the treatment plan in order to feel better. And so one of these treatment plans may include this use of continuous positive airway pressure, a CPAP machine, in the treatment. And unfortunately, this is usually the treatment of choice. Continuous positive airway pressure prevents collapse of the upper airway through the use of pressure delivered through the use of a nasal, oral, or oronasal mask during sleep. So this patient is going to wear a mask, very similar to an O2 mask, only this will deliver that ventilation, that positive airway pressure, preventing the collapse of the airway so that there is no snoring. They get the air or the oxygen that they need, so there is no collapse. They get a better sleep because air is getting to the brain, and they feel better in the morning when they wake. So a CPAP machine will deliver a continuous stream of positive pressure, keeping the airway open, providing an unobstructed airway. And so this is what you will see. They're going to put on this mask. There's the air pressure hose, and then you can see the positive pressure device that is offering and delivering this ventilation. This is all about ventilation. And so what happens, because this air is being forced in, the airway remains open. The airway remains open. And this is just the frontal view of the patient wearing the mask. So patients are taught about operation. They're taught about care of the machine, maintenance of the machine, how to handle the machine, how to clean the machine, how to clean the tubings. Weight management and loss is encouraged because we know that obesity is a problem in patients with obstructive sleep apnea. So if we can get them to lose some weight, they may not need to use the machine anymore. Positioning during sleep in a non-supine position by using pillows is an effective secondary intervention. And they also need to avoid alcohol and sedatives before bedtime, right? Because we know that this relaxes the body even more and will contribute to the relaxation and the narrowing of those airways. However, using this mask can cause a lot of apprehension and a lot of anxiety with these patients. So these patients may want to have a glass of wine, they might want to have a beer, they might want to take a sedative because using the mask will make them anxious, but it is going to only contribute to the narrowing of those airways. So some oral appliances that are custom made for the patient may be used to maintain airway patency. So sometimes the patients cannot use a mask. And so that's when doctor will say, okay, and they will direct them to a dentist or an oral surgeon for this oral appliance to maintain the airway. And these appliances assist with mandibular repositioning to hold the mandible in a forward position to keep the airway open. But many times what happens is they are able to put the oral appliance in and it works great when they're falling asleep, but it will become dislodged when everything relaxes and they fall asleep. So Complications. Obstructive sleep apnea is recognized as a mediator of cardiovascular disease because of recurrent hypoxemia, right? No ventilation. The release of inflammatory mediators such as endothelins, and these are proteins that will constrict blood vessels, and then insulin resistance, right? So there's cardiovascular disease, there's hypoxemia, and then there's insulin resistance that is all going to contribute to obstructive sleep apnea. So in response to hypoxemia, inflammatory mediators are released, which leads to the adherence of white blood cells to the endothelium, causing damage and then increasing atherosclerosis, right? And we know that atherosclerosis, it has to do with the arterial walls, right? So if this hypoxemia remains untreated, then we know that they are on their way to cardiovascular disease. So severe nocturnal hypoxemia can result in cardiac ischemia, which is death of the heart muscle, myocardial infarction, they're going to have a heart attack, stroke, may contribute to AFib, may contribute to heart failure, and then sudden cardiac death. So, true obstructive sleep apnea really needs to be addressed. Your clients need to follow a treatment plan, and they need to possibly lose weight so that the body stays in that state of homeostasis, that term that Professor Johns loves so much, homeostasis, where all is well and they do not go into this hypoxemic state, this acidotic state. Some surgical procedures are classified as primary or secondary interventions, and this is for patients that have a physical problem in the airway, a polyp or a tumor that is contributing to the obstructive sleep apnea. Surgical procedures are considered primary interventions for patients with severe obstructing anatomy that surgery can correct. So if this is a physical problem that is causing this obstructive sleep apnea, then we can do surgery and somehow fix the anatomy. Surgery is considered a secondary intervention in patients who are intolerant of CPAP or the oral appliances. So somebody who cannot tolerate the CPAP machine, somebody who cannot use an oral appliance, but they are still having this obstructive sleep apnea, surgery would be a secondary intervention for these patients because it is really not a physical reason that is causing the obstructive sleep apnea. Surgical procedures remove excess tissue in the airway that can interfere with sustaining adequate airflow. And then there's bariatric surgery to facilitate weight reduction. Sometimes that can be a consideration. So, nursing management. What do we do? So, symptoms are due to the relaxation of soft tissue in the upper airway, resulting in occlusion of the airway. This is what we know. So we need to instruct the patient on the better choice of using the CPAP machine because of the occlusion of the airway, the patient will snore, and then there will be periods of apnea. So during apnea, there is no oxygen exchange, resulting in hypoxia and then hypercapnia, which leads to that acidotic state, leading to respiratory arrest. So we need to instruct them on the management of their symptomology. So some nursing diagnoses. Sleep deprivation related to inability to breathe during sleep. They are not breathing well. Sometimes they're not breathing at all. Anxiety related to inability to breathe during sleep. If they have already been diagnosed with obstructive sleep apnea, and if the patient understands that during these apneic phases, they are not breathing and that they are at risk for passing away, that is going to make them very anxious, right, about going to sleep. They're never going to want to go to sleep. And sometimes there is anxiety related to using the CPAP machine. They know that they have this mask over their face and they may view it, for, at least for a little bit of time, as a negative until they get better sleep and begin to feel better during the day. Risk for decreased cardiac tissue perfusion related to the hypoxia during sleep. Ineffective breathing pattern, right? They do have an ineffective breathing pattern related to cessation of breathing during sleep or even when they're snoring. And then risk for injury related to their daytime sleepiness. If they are driving a car and they are so sleepy during the day, if they're driving home from work, or if they have a job where they have to travel from place to place, and they have this daytime sleepiness, there is risk for injury. So nursing interventions, what are we going to do? We are nurses. What are we going to do? Well, we're going to assess. We are going to assess, and then we are going to reassess. We are looking at vital signs. Hypertension and dysrhythmias are common findings due to hypoxia and release of these inflammatory mediators as a result of the apneic episodes. So we know that there is going to be an alteration in their vital signs because they are not feeling well. We're going to look at height and weight because obesity is a risk factor. We are going to look at their rest, their sleep, and their activity history. We are going to assess for edema, bleeding, and respiratory distress post-op if they have gone to surgery. So if they've gone to surgery, right, we are concerned about edema in the throat where that airway is the airway remaining patent? We're looking for bleeding. Are they coughing up blood? Do they feel as though they're swallowing a blood clot? And then we are looking at respiratory distress. Are they short of breath? Are they breathing well? Do they need supplemental oxygen? Because surgical procedures will put the patient at risk for bleeding, and procedures in the area that can cause respiratory distress if swelling occurs, right? So if they have undergone surgery, then we need to look at this airway and making sure that the airway remains patent. We are going to administer medications as they are ordered. Patients may have uncontrolled hypertension or cardiac dysrhythmias. So we have to look at their blood pressure. Do they need something to control their blood pressure because of this obstructive sleep apnea? Do they have a cardiac dysrhythmia? Do they need a medication to regulate their heart rate? They may need diagnostic testing. And then patient education. We need to educate them on the disease process of this obstructive sleep apnea. We need to talk to them about medications that they may be using that doctor may have ordered. They need instruction on this CPAP machine and the reason for the CPAP machine. And then we need to instruct the patient, listen up, listen up, listen up. We need to instruct the patient on relaxation exercises to reduce that uncomfortable feeling from the mask. Because what do we know? What do we know about our patients, and what do we know about human nature in general? And that is, if something is uncomfortable to us, we are not going to use it. So if your patient is feeling anxious, or if they are uncomfortable using this CPAP machine or this mask, what do we know? They're not going to use it, right? They're not going to use it because it makes them uncomfortable. I can't sleep with this mask on. I can't sleep without it, but I definitely can't sleep with the mask on. So by instructing them on doing some relaxation exercises before bedtime, by instituting a bedtime hygiene where they do the same thing every night, whether it's taking a bath, whether it's reading a book, whether it's listening to a relaxation exercise on their phone or with headphones to get them into a relaxed state, where they are more comfortable using the mask and falling asleep with the mask on, right? The one thing that we don't want them to do is we don't want them to have a relaxation session with a glass of wine, right? Because we don't like sedatives and we don't like sleeping pills, right? So we don't want to use any of these things. We need a good bedtime hygiene, and we need those relaxation exercises so that when they put their mask on, they are feeling comfortable. There is less anxiety. We can also talk to them about weight reduction and weight management, because obesity is a risk factor for sleep apnea. So, how do we know that we've done a good job caring for these patients? What do we know? We know that weight loss and the use of CPAP at night will help control their obstructive sleep apnea. So if they are using the CPAP, or if they have experienced some weight loss, then we know that we've done a good job. Patients who are well managed will verbalize improved sleep patterns. They feel better waking in the morning. There are fewer nighttime awakenings. They're not waking up. They're not waking up gasping for air. They're not waking up from snoring. They're not waking up choking because they are using the CPAP. There is less daytime sleepiness and fatigue because they are sleeping better at night. There is improved mental alertness. They are less irritable. And patients with hypertension, their control of blood pressure values will be achieved. So there is a lot of benefit here to using the CPAP machine, but they need to be compliant in using the CPAP. So laryngitis. Laryngitis is the most common disorder of the larynx. Causes include upper respiratory infections, environmental pollutants. Sometimes if you have GERD, you will have gastroesophageal reflux disease. You will have periods of laryngitis from that bile backing up. And use of asthma inhalers will sometimes give you laryngitis. Vocal misuse can result in acute laryngitis, and attempts to maintain speech can further strain the vocal cords. Vocal strain can occur from prolonged periods of talking, which may be seen in teachers, lawyers, anybody that has to talk a lot. So, and I have noticed this with myself, and you may have noticed this in my voiceovers, in my recordings, that sometimes my voice is very strong, sometimes my voice is hoarse, and that is because I might be doing these voiceovers in shortened periods. I might have to take a break in between. And sometimes if I have a clinical day and then I'm teaching, whether during the day or teaching in the evening time, and there is a lot of talking going on, then my voice does tend to become a little hoarse. And for that, I do apologize. So endotracheal intubation may also cause laryngeal edema, and lung or throat cancer may manifest as laryngitis. So pathophysiology and clinical manifestations. What are we going to see? What is your patient going to talk about? So laryngitis is an inflammation of the mucous membranes of the larynx. The predominant symptom is hoarseness, where, and you will hear this with me an awful lot, and again, I apologize. But it can also include symptoms similar to those of upper respiratory infections, such as a cough, postnasal drip, fatigue, and malaise. And this year, I do seem to be suffering from allergies a lot more than I ever have. I do not know why. So I do complain sometimes of being dry and drinking a lot more water, which is not necessarily a bad thing, but it is because I am so dry from taking an antihistamine and then for the postnasal drip. So laryngitis symptoms will usually last 7 to 10 days, but I cannot usually rest my voice for 7 to 10 days. I have to do a lot of talking. So endotracheal intubation may cause laryngitis. resulting in extreme airway obstruction and stridor. And stridor is that high-pitched wheezing breath sound caused by turbulent airflow in a partially obstructed larynx, right? And sometimes you will hear this in small children. You will hear stridor in small children. You will hear it in adults also, but more oftentimes with small children. So diagnosis is based upon patient complaint of hoarseness, related to a recurrent or recent upper respiratory infection, although with me it has to do with a lot of talking. So patients may require visual examination of the larynx by an ear, nose, and throat specialist with a laryngeal mirror or a laryngoscopy. I'm sorry, I have a hard time with that word, I'm sorry. But that is when doctor goes down with a very, very small, thin tube and he takes a look at the larynx to see what's going on there. So if polyps, inflammation, or tumors are present, then doctor may go on to order an X-ray or a CT, a CAT scan. Treatment. What are we going to do for this laryngitis? Well, treatment consists of voice rest. If you can rest your voice, I cannot. So adding moisture to the air in the home with a humidifier or a vaporizer, and then again drinking plenty of fluids, and I do try. Avoidance of smoking and exposure to secondhand smoke is also important because that is going to irritate those membranes. Use of antibiotics is indicated if a bacterial infection is present, and if laryngitis lasts greater than 5 days after appropriate treatment and voice rest, then we need to look at other reasons. So if somebody comes in and they're complaining of laryngitis and their voice is hoarse, and so we're going to tell them to do all of these things. Rest your voice, try using a humidifier or a vaporizer, plenty of fluids to keep everything nice and moist in there, and don't take anything that's going to dry you out. And after 5 days, if the laryngitis persists, then we have to go back and reevaluate, and we are looking for the presence of a malignancy, or is there something abnormal that is going on with the larynx. So symptoms are due to inflammation of the larynx resulting in vocal hoarseness or the absence of voice, which I have. Additional symptoms may include a dry throat, difficulty swallowing, and a fever and a cough. So some nursing diagnoses for laryngitis are impaired verbal communication related to the inflammatory process. We are not communicating well. And there are days when, yes, I do understand that I am not communicating well, but again, I am not at liberty to rest my voice, so I am sorry for the way I sound. Risk for infection related to the inflammatory process, and then risk for aspiration also related to the inflammatory process. So we are nurses, and what are we going to do? Well, you know what we're going to do. We are going to assess, and then we are going to go back and reassess. And we are going to start with vital signs and that temperature elevation that may indicate an infection. So, assessment of the throat structures. Increased edema of the throat structures could compromise patency of the airway, and we know this. When that airway becomes edematous, we know that there's a problem there, that the airway will no longer be patent. Assess for presence of stridor after an extubation, right? And this is a big catch-22 because many times you need to be intubated, or your patient will need to be intubated because of increased edema, right, for whatever reason. And so we're going to intubate them, which is going to irritate that airway even more because it's a foreign body within the body, in the airway. And then stridor will indicate an acute obstruction of the airway and is a medical emergency that may require re-intubation. So what happens is that your patient is intubated for this increased edema for whatever reason. And so now doctor says, well, I think they're okay. I think all will be well. Let's try and extubate them. So we extubate you, and in extubation, those passageways become edematous because they're irritated now, and then your patient will develop that stridor, which could indicate the narrowing again of the airway. So then what happens is that your patient may need to be re-intubated. So it's a big catch-22 there. We are going to administer humidification in supplemental oxygen as it is ordered, and then sometimes your patient just needs a humidifier in the room. They may not need supplemental oxygen, so if they're at home, we just may be able to educate them to say, put a humidifier or put a vaporizer in your room to put added moisture in the air so that your mucus passages are moist, and that will help with the laryngitis. And then if there is an infection present, antibiotics as ordered to treat the infection. So if your patient is hoarse and if there is that stridor, then you need to have emergency airway equipment available to re-intubate if necessary, because that will indicate a medical emergency. That airway is becoming occluded, obstructed, whatever you want to call it. But the bottom line is that airway is closing, and we need to re-intubate to get that ventilation going. And then we need to provide alternatives for communication, whether they are on the ventilator or whether they are just being following voice rest. They need to be able to communicate. Pen, paper, communication board. If they have a cell phone, can they text messages or can they do something with their cell phone? And then patient education. Always patient education on medication use, instructing patient on voice rest, and the need to use alternative modes of communication if they can rest their voice, because continued use of voice will cause strain and delay resolution of the laryngitis. So the more I talk, the more hoarse I become, and then the worse I sound. Increase intake of fluids because we want to keep everything moist. We want to alleviate that dryness. If they are smokers, we need to talk to them about smoking cessation, or at least cutting back on smoking, because smoking will irritate the larynx and it will just exacerbate the symptoms. It's just going to make the symptoms more worse. Or that was terrible. There's no such word as more worse. It will just make the symptoms worse. I'm sorry, I do apologize. So how do we know in taking care of this patient with laryngitis? How do we know that we've done a good job? Well, the patient's voice will return to normal, and there will be resolution of any accompanying symptoms reflecting resolution of the laryngitis, and then the effectiveness of the treatment. So if it is just laryngitis for laryngitis sake, if they rest their voice, if they use a different mode of communication, if they put the vaporizer or the humidifier in their room and keep everything nice and moist, if they increase their fluid intake and they are able to alleviate that dryness, and then your patient's voice returns to normal, then you have done a great job. Good job. But in patients who develop acute laryngitis post-extubation, resolution of stridor, ease of breathing, and adequate oxygenation levels will indicate decreased obstruction and then the resolution of laryngitis. So, post-extubation, if they are breathing easy, if that stridor resolves, their oxygenation levels remain normal, then we have known that we have done a very, very good job in caring with this patient that developed a laryngitis and then had to be intubated. So, laryngeal cancer. Laryngeal cancer. In 2012, the American Cancer Society reported that in 2014, there were expected to be approximately 13,000 diagnoses of laryngeal cancer. Diagnoses are split into approximately 10,000 men and approximately 3,000 women, right, to make up the 13,000 cases. Now, so in 2012, we are already predicting that in 2014, laryngeal cancer diagnoses are going to increase, right? So it was estimated that there were 4,000 deaths in 2014. And we can attribute all of this to what? What is the most common cause of laryngeal cancer? And that is smoking. So, risk factors for laryngeal cancer include tobacco and alcohol use, poor dietary habits, a compromised immune system, genetics, occupational hazards where they are around a carcinogen, gender, age, race, and GERD. Yes, believe it or not, GERD is a contributing factor to laryngeal cancer. Why? Because those acids, those bile acids in GERD there's esophageal reflux, and those acids come up and they will affect the larynx. So, use of tobacco in any form is the most important risk factor for development of cancers of the head and neck. So, cigarettes, pipes, cigars, and all forms of chewing tobacco raise the risk because of the chemicals contained in these tobacco products. So, alcohol ingestion combined with tobacco, because, right, you're well, I don't know, maybe so much now. Well, maybe increase now, yes, because people can drink outside. So, there is that person who enjoys a nice glass of wine and a cigarette at the same time, or likes having their beer and a cigarette at the same time. So, alcohol ingestion combined with tobacco use will increase the risk up to 100 times. Up to 100 times. So, in patients with a history of alcohol abuse, poor dietary habits are also often present, resulting in a lack of fiber intake and foods containing vitamins, because these patients would rather drink than eat. That is the bottom line. If I have a choice of eating or drinking, I am going to drink. It is more common in people who have compromised immune status as a result of immunosuppressant drugs after an organ transplant, hereditary disease or AIDS, occupation where workers have intense and long exposure to certain chemicals, wood, coal or steel dust, or paint fumes, and asbestos are at a higher risk. About 4 times more uncommon in men than in women, but these statistics are changing. Laryngeal cancer is slow growing, so more than half the people diagnosed are over age 65. It is more common in African Americans and Caucasians than Latinos and Asians. Why? Because more African Americans and Caucasians will smoke. Okay, so pathophysiology of laryngeal cancer. It usually originates from the squamous cells that line the larynx and the hypopharynx. So changes in the squamous cells from irritation, usually from heavy drinking and smoking, result in the squamous cells becoming precancerous. According to the American Cancer Society, most precancerous cells do not become cancers if the irritant is removed. So, once we know if someone is smoking and drinking, and for whatever reason, maybe they have a bronchitis, maybe they have a laryngitis, and doctor has occasion to do some testing, then we know, or we could know, that there would be irritation and that the squamous cells are abnormal. So, according to the American Cancer Society, these precancerous cells will not become cancers if the irritant is removed. So what does this mean? This means that the patient or the client would have to stop smoking. And we know that that does not always happen, right? And so here you will see the structures of the larynx. You can see where the tongue is, the esophagus, the trachea, and then everything that comprises the larynx, which is the epiglottis, the supraglottis, the vocal cords, the glottis, and then the subglottis. So you can see how smoking, drinking, and just physical abuse of this area would contribute to a cancerous diagnosis. So now the vocal cords. So here we go. On the left, as you're looking at the slide, you can see healthy vocal cords, right? They look great. They everything there is nice, pink tissue, very healthy looking. And then on the right, as you look at the slide, you will see the laryngeal cancer on the vocal cords. You can see the cancerous tissue. So clinical manifestations, what are we going to see? What is the patient going to say? Well, they're going to be hoarse, or there will be a change in their voice that does not resolve in 2 weeks. Now remember, when we were talking about laryngitis and we were talking about hoarseness and the voice irritation and all that, we talked about 5 days, right? 5 days. So something that goes on for 2 weeks or longer, we need to look into this. Voice changes include lower than usual pitch, and it is raspy and very hoarse sounds, much like I probably sound to you right now. Additional symptoms will be a persistent sore throat, a constant cough, pain with swallowing when they're eating, ear pain that does not go away, difficulty swallowing, where they want to swallow, but it's not only painful, but it's difficult for them to do. Trouble breathing, a lump or a mass in the neck, and then weight loss due because of the difficulty with eating, the painful swallowing, the inability to swallow. So diagnosis. Diagnosis will start with the completion of a thorough health history, right? That's where we always start, including general health information. Do they have any other medical conditions? How long have they had these symptoms? Because remember, the time frame is 2 weeks, so anything longer than 2 weeks. Do they have any risk factors? Are they a smoker? Are they a drinker? Are they a diabetic? And then family history. Is there any history of cancer within the family? Then we're going to move on to the physical assessment. We're going to look at the neck. We're looking at the thyroid lymph nodes. We're looking at muscle movement of the neck, which could indicate if there is a tumor that we may be able to see. If not, we may have to move on to radiology. So if initial findings, this would be something in the health history or in the physical assessment, are suspicious for laryngeal cancer, then we are going to make a referral to an otolaryngologist. Again, there's that word, which is an ear, nose, and throat specialist, or a head and neck surgeon, depending on what doctor feels is more appropriate. So diagnosis, we are going to do diagnostic procedures, including endoscopy, and we're going to do some imaging. Laryngoscopy allows for the assessment of the vocal fields and the glottis for the presence of ulcerations. Are there any nodules? Do they have polyps? Strictures. Is there bleeding? Can we see a tumor? Then we may have to do a biopsy. So biopsies are performed under general anesthesia, and we want to obtain this tissue to send it for evaluation. Other diagnostic studies may include a barium swallow. We've all seen those. We've all heard those. That's when we drink the barium, we drink the contrast, and then we follow it on imaging, the way we swallow it, the way it goes into the digestive system. Chest x-ray, we may do a CT, doctor may want an MRI, and he might also want a positron emission tomography scan, which is a PET scan. And so the barium swallow will evaluate the throat and then the ability to swallow. Because if it is laryngeal cancer, then that is where the problem is going to be, right? It's going to be in the throat, and it is going to have to do with the ability to swallow. Is swallowing painful? Are they able to eat? Do they have difficulty swallowing? Is the airway patent? That's another reason why we need to look at the throat. And so here is just a visual of doctor doing the laryngoscopy to obtain possibly that tissue. So diagnosis. Chest x-rays are obtained to evaluate the lungs for the presence of a lung cancer, because doesn't it just make sense that if your patient is a smoker and if he has laryngeal cancer, that he may also have a lung cancer? So the CT, the MRI, and the PET scans are completed to determine the presence of metastasis into the surrounding and distant soft tissues and for regional adenopathy, and then we're looking for lymph node involvement. So now we know that we have the presence here. So now we know that we have a malignancy. The question now becomes, has it spread? Is there metastasis? Has it moved on? So information obtained through biopsies and diagnostic imaging is used to determine the stage of the tumor and then disease progression. Lab testing is also done to provide information about the overall health status of the patient. So we're going to do CBC, we're going to do a basic metabolic panel, we're going to do all of these lab studies that are done routinely, and then hopefully this is someone who has been having routine lab studies done, so we will have studies to compare it to see if we now have an abnormal result. So a complete blood count, the CBC, blood chemistry profile, coags, bleeding profiles, and a urinalysis will provide information about the potential spread of the laryngeal cancer. Their nutritional status. Remember, this is someone who may be having difficulty swallowing, difficulty eating, and then organ functions such as the kidneys and the liver. So at present, there is no specific blood test or marker to assist in diagnosing laryngeal cancer. So it is all done with history and physical. It is done with the physical assessment, and then we move on to diagnostics, and then we may do some lab studies. So if the cancer is diagnosed, prognosis is dependent upon the stage of the disease, the size, the location, the grade of the tumor, and the general health status, age, and gender of the patient. So what is their overall health? If their overall health status is fair, let's say, and maybe they were a smoker in the past, or maybe they were an occasional smoker and they developed this laryngeal cancer, but they're not overweight, they're not a diabetic, they have no cardiovascular disease, overall their health status is fair to good, then their prognosis is good. So based upon factors such as the stage of the disease, the location, and then the size of the tumor, and then whether the current tumor is a recurrence. Is this the first time your patient is having cancer, or is this a recurrence of the cancer? Treatment will include radiation therapy, surgery, and possibly chemotherapy, sometimes all three. Radiation therapy is used to eliminate cancer cells and then maintain the structure and the function of the larynx. Because remember, we want to keep all of this intact. We want to eliminate the cancer, but we want to keep the structures intact because we still want it to be able to function if it can. Radiation therapy is used to treat small tumors, reduce tumor size prior to surgery, or it is used in patients who are unable to undergo therapy. And then radiation therapy is usually given 5 days a week, so they will go Monday through Friday for 6 to 8 weeks. Okay, and again, this is for small tumors. We're going to do this to help reduce the tumor size. So if it is a very large tumor, sometimes doctor will say, let's do some radiation. Let's try and shrink the tumor so that it is less traumatic to the body, and I stand a better chance of removing all of the tumor if the tumor is shrunk. So some side effects of radiation will include increased hoarseness. So yes, I know that we're looking at hoarseness, but sometimes a side effect of the radiation will be the hoarseness. Prolonged tissue healing, because remember, this is an area, we are radiating an area where it is constantly exposed to something, because your patient has to eat, your patient has to drink, right? So it's being constantly exposed to something. There's going to be a sore throat because that's where we're radiating, right? Difficulty swallowing. And if the salivary glands are involved, a dry mouth, xerostomia, dry mouth, all of because of this radiation. So we need to take care with the patient's skin. No harsh soap, no lotion, no lotion. Listen up, listen up, listen up. We are going to take great care with this patient's skin. It may be red, it may be blistered, it may be peeling. So therefore, no lotions, absolutely none. No harsh soaps. We are going to recommend that the patient use a soft bristle toothbrush because of the area that we are radiating. We do not want to risk irritation or inflammation of those gums. Right? And no acidic, no spicy foods. Now, I know that this should probably be a given. You know, we are radiating this throat. They're having difficulty swallowing. Their throat is sore. But yet, they want to eat something hot, or they want to eat something spicy, or they want to eat something acidic. It just doesn't make sense to me why they would want to go that way. So we need to instruct them that this acidic food, this spicy food, needs to be put aside, at least for the time that they are receiving radiation. So chemotherapy can be used in several different ways. It can be used at the same time as radiation therapy, and we call this chemoradiation. So your patient will receive radiation Monday through Friday for 6 to 8 weeks, or whatever doctor says, and at the same time, they may be receiving a chemotherapy treatment also. And so the chemotherapy will improve the effectiveness of the radiation in conquering the cancer, or we hope to conquer the cancer. So chemotherapy can be given before radiation therapy to shrink the larger tumors and then make radiation more effective. So sometimes they will do chemotherapy, the tumor will shrink a little bit, and then they can say, okay, now let's do some radiation and see if we can get it to shrink even more, and then maybe doctor may be able to remove the tumor altogether. It can be also given prior to surgery to shrink larger tumors that are not easily excised. So if surgery is the option, if what doctor wants to do is surgically remove the tumor, he may say, let's do a little chemo, let's try and shrink the tumor so that there is less danger when I go in to excise the tumor. And it can also be used as a palliative intervention. So now palliative means that they may not be getting any better. Okay, this laryngeal cancer is there. Maybe they have gone through chemo, maybe they've gone through radiation, maybe we've tried to remove the tumor, maybe we've done all we can and the tumor has come back. And so now we moved on to palliative measures. And sometimes we know that in giving patient chemotherapy at this time is not going to fix the problem. It is purely palliative to make them more comfortable and relieve some of the symptoms. Okay, so this is not chemotherapy to cure the cancer or to remove the cancer. It is to relieve symptoms. So surgical management, let's think about lists. Surgical management. So surgical procedures include laser surgery, which would be optimal, right? Because then the patient doesn't undergo an actually incision. Cordectomy, partial laryngotomy, and then the total laryngotomy. So the goal of surgical treatment is to remove the tumor, however, maintaining the structure and the function of the larynx, right? This is the goal. That would be the ultimate goal of the surgery. To maintain the function of the larynx, we want to maintain their speech, their ability to swallow, their ability to breathe. Laser microsurgery is used to treat early forms of glottic cancers and is now considered the standard approach at many facilities. So yes, we want to do laser if we can. It will result in good functional outcomes and it will cause minimal morbidity, right? So this would be a good choice. Doctor would talk to the patient about this choice. Chordectomy is the removal or part of all of the vocal cords through the use of a transoral laser. And so with this, then the patient would have to understand that they may, most likely, probably would, lose the ability to speak. So if cancer is present unilaterally on the vocal cords and is in the early stages, this option may be considered, right? The laser. Partial laryngotomy is performed the part of the larynx in the early stages. So we're going to remove part of the larynx, only one vocal cord, and then the tumor. That would be a partial laryngotomy. So preservation of the voice, which may be slightly altered or hoarse, is achieved because of the presence of the remaining structures. So in a partial laryngectomy, I am removing only what is diseased. I am removing only what is cancerous. So I'm only going to remove part of the larynx, one vocal cord, and then the tumor. So this will leave everything else. This will leave the patient with part of his larynx, the other vocal cord, and then the tumor is gone. Patients remain being able to breathe normally. However, there may be the temporary tracheostomy may be required to protect the airway. So remember, when we talked about tracheostomies, we said that tracheostomies could be temporary or they could be permanent. In this case, it would start out as temporary, and moving on, we would hope that it would remain temporary and that the tracheostomy would be able to be closed. So, a total laryngectomy is the complete removal of the larynx. We are taking away everything. We are taking away the larynx, we're taking away the vocal cords, and we are taking away the tumor. So in advanced stages where the cancer has spread beyond the vocal cords, this is a curative procedure. So the larynx and the several rings of the trachea are removed. Swallowing ability will remain normal, but will result in the inability to speak. So they will be able to swallow, but because we are taking the vocal cords, they will not be able to speak. Creation of a tracheostomy is required for breathing and because of the risk of aspiration of fluids and food after removing the epiglottis. So here, this tracheostomy may be temporary, or in this case, it may be permanent. So the laryngectomy. So here you can see before the laryngectomy, you can see the tongue, the larynx, the pharynx, the vocal cords, the esophagus, and the trachea. You can see all of that. And then after the laryngectomy, you can see where they made the stoma, and then you can see the esophagus and then the trachea. You understand? So the larynx is totally removed. Totally removed. The vocal cords are gone. So, survival is based upon timing of the diagnosis. So again, this is not something that should wait. Remember, there is that 2-week time frame. If hoarseness or sore throat, difficulty swallowing goes beyond that 2-week period, it needs to be evaluated. So survival is going to be based upon timing of diagnosis and if there is mets to the lymph nodes or other organs, right? Because if there's been metastasis, then that means that they've had this tumor for quite a bit of time. Early diagnosis has a high cure rate, right? Because we're on top of it. With a 5-year survival rate, approximately 80 to 95%. So that's pretty good, right? If after 5 years, I am still 95% cured. Advanced staging at diagnosis has a 5-year survival rate of approximately 25 to 50%. So that pretty much cuts my chances in half, right? So this is something that we want to evaluate. We want to talk to our patients about these symptoms, especially if they are drinkers, especially if they're smokers, and especially if there is a distortion in their voice. Other factors that will influence survival rates include the patient's general health. Are they overall healthy? Their age, their immune function, and the presence of comorbidities such as diabetes, heart disease, or hypertension, because all of this will play a part in whether or not they develop another problem after the surgery. Smoking cessation, again, it is a no-brainer. It is a no-brainer. And this is probably the single most thing that will increase their survival, and that is they need to stop smoking. And because of the age of patients diagnosed, usually in the 60 to 70-year age group, cause of death may be related to other issues. Because remember, they, 60 to 70 years, they may already have cardiac disease. They may already have hypertension. They already may have been a diabetic for a very, very long time. So let's talk about smoking cessation, because this is very, very important in treating this patient. So it's hard to do, right? Smoking is very hard to do. I am not a smoker myself. I have never been a smoker. Well, I did, but it really did. It was, it was really a no-brainer. So first line medication therapy is the nicotine replacement therapies, including the nicotine gum, the nicotine patches, or the nicotine lozenges. Listen up, listen up, listen up. The first line medication therapy for smoking cessation is nicotine replacement therapies such as the nicotine gum, the nicotine patches, or the nicotine lozenges. After that, there is the non-nicotine therapy such as the Chantix or the Zyban. Now, second line, we can go to other medications such as clonidine and nortriptyline. These will assist in helping the patient to stop smoking. But the first line treatment therapy for medication in smoking cessation is the nicotine replacement therapies such as the nicotine gum, the nicotine patches, or the nicotine lozenges. After that, we have to figure out why they smoke. Well, of course we know why they smoke, right? They smoke because they like it. But some people don't. Some people smoke when they're anxious. Some people smoke because it's habit. Some people smoke when they're just being social. They're out, they're having a drink, and they might want a cigarette. Some people have one after a meal. Some people have one because it's what they've done for years. First thing in the morning, they get their coffee and they grab a cigarette. And then sometimes just changing what you do, you can I don't want to say break the habit, but you can start a new habit. For instance, when my mother-in-law needed to stop smoking, she used to get up in the morning and she used to get her newspaper, she used to get her coffee, and she would have a cigarette while she was reading the newspaper. Well, when she wanted to stop smoking, she could no longer have that coffee in the morning with her newspaper. So what she did was, when she would wake up in the morning, she replaced the coffee with tea, because she did not associate that cigarette with tea in the morning. She never associated that. So by replacing the coffee with tea in the morning, she was able to develop a new habit and at least take away that cigarette for first thing in the morning. So behavioral and counseling therapy is providing support And this increases the likelihood of success and can be in the form of group or individual counseling or telephone conversations, because now everything is telehealth, right? So sometimes if you can find out why they're smoking, is it a habit? Do they not really enjoy it, but it's just a habit? Or do they really rely on it? Is it something that they really do because they need to do it? Then that's a whole different conversation. But sometimes just replacing the habit with a new habit will increase their likelihood of success. And then physical activity. Increasing physical activity will decrease cravings. And we know this, right? Because even with weight loss, if we increase our physical activity with weight loss, sometimes we can replace the craving with a physical activity, such as, I would really like to have a bag of chips, I would really like to have my soda, I would really like to have a candy bar, but instead of doing that, I might do it, but I'm going to go and take a walk first, or I'm going to get up, I'm going to walk down the hall, I'm going to get something to drink, I'm going to go and talk to someone, and maybe I'll make a phone call. And then after all of that, if I still want the soda, if I still want the chips, if I still want the candy bar, well, then I guess I'm going to have it. But if we increase our physical activity, we already know that this has an effect on the brain and that it will decrease the cravings and then symptoms of anxiety, depression, and stress that may be experienced during smoking cessation. Because remember, stopping a habit or starting a new habit with a habit that to replace a habit that already exists is going to put the body under stress, because the body is used to doing things one way. So once we say to the body, we're not going to do it this way this time, we're going to do this, that puts the body under stress. So if we increase our physical activity, it will help to decrease the cravings and then the symptoms of anxiety, depression, and stress that is going to put the body under stress as we are stopping our smoking. Please take note. And also, increasing physical activity and exercise can also help reduce the weight gain that some people experience post-smoking cessation. So please take note of this slide. Listen up, listen up, listen up, and take note. So, nursing management of these patients with cancer. Symptoms are dependent upon the location of the cancer, right? We know this. It will affect the vocal cords. It can result in changes in voice quality and character or that hoarseness. However, a lump in the neck, an earache, a sore throat can be seen in tumors above the vocal cords, right? So some nursing diagnoses for laryngeal cancer. Ineffective airway clearance related to surgical removal of the glottis. So if they have gone to surgery, ineffective airway clearance related to surgical removal of the glottis. Impaired swallowing related to laryngectomy or a tracheostomy tube, right? Because we know that's going to impair their swallowing. They're not going to have any swallowing. Impaired vocal communication related to removal of the larynx. Impaired body image related to the surgical procedure, because remember, if they are going to have this tracheostomy, whether it is either temporary or permanent, there is going to be an impaired body image. They're going to look different. Grieving related to the change in body image, role performance, and then potential death. They are grieving for the person that they used to be, right? Because they don't look the same anymore. They are not going to look the same, especially if this tracheostomy is going to be permanent. Their role performance. If this is a man, let's think about this. If this is a man or a head of a household, or even a woman who was a head of a household, and now she has to think, can I support my family? How will I support my family? Is my family going to view me differently because I now have this tracheostomy or I now have this cancer? And then potential death. Is this something, I know I may be fine now, but is this something that can come back and take my life? Risk for nutritional balance, less than body requirement, related to impaired swallowing. Because remember, these patients, before they're diagnosed or as they're diagnosed, they have that difficulty swallowing. It is painful for them to swallow. So, nursing interventions. We are nurses. You know what we're going to do. We are going to assess and then, we are going to reassess. And we are going to look at a complete review of risk factors. So we are going to look on their smoking, their alcohol use, and do they have an occupational exposure to chemicals? What do they do for a living? Review of symptoms and then their complaints. Hoarseness, earache, sore throat lasting several weeks, need further evaluation. Remember that 2-week time frame. Skin assessment. They are going to have red, tender, and peeling skin if they are going through radiation therapy. So, patients should avoid the sun during radiation therapy. It will be helpful if they wear loose-fitting clothing to avoid skin irritation. Anything, they should have nothing actually up around that neck area. And we want to talk to them about using a mild soap. They need to use a mild soap and no lotions. No lotions. Listen up, listen up, listen up, and do you hear me? Please take note. No sun during radiation therapy. Loose fitting clothing to avoid irritating that skin when they are going through radiation therapy. And then they should be educated to use a mild soap. So oxygenation status, right? This is important because we want to know about that airway. We want to make sure it's patency. So shortness of breath and decreased pulse ox may indicate edema and increased secretions post-operatively at the operative site, putting the airway at risk. So you are going to assess that oxygenation status. If they are receiving chemotherapy, and if you are a chemotherapy certified nurse, you will administer this chemotherapy as ordered. Okay, you can only administer chemotherapy if you are chemo certified. Tracheostomy care as needed, but at least once a shift. We are going to institute aspiration precautions, right? Because not whether they have a tracheostomy or not, they are going to be at risk for aspiration. So post-operatively, the patient is at risk for aspiration because of removal of the upper airway structures and the epiglottis, right? If they have that tracheostomy. Provide means for communication. So post-laryngectomy, the patient will not be able to speak. They will not be able to speak. So they need pen, paper, picture board, cell phone, anything that they can use to communicate and make their needs known. Then, now, we have to think about nutrition. So we need a nutritional consult, and then we are going to put them on a calorie count. Small, frequent meals throughout the day. Listen up, listen up, listen up. Small, frequent meals throughout the day. Please take note. Large meals are going to be overwhelming for this patient, and it will not be good for them. They may not be able to swallow a large meal or a large amount of food. Small, frequent meals throughout the day. Please take note. So because of swallowing impairment and necessary surgical interventions, the patient may not have adequate nutritional intake for wound healing. So they may have to supplement, Ensure, Boost, anything like that. Patient education. Diagnostic testing and interventions such as direct laryngoscopy, and then disease management. Understand the outcomes such as loss of speech and creation of a tracheostomy is essential. So they have to understand that yes, we are going to do this, but you will lose the ability of speech and you are going to have this trach. They need to have all of this education and become very familiar with it, or as comfortable as they can be before they go to surgery. And then tracheostomy management. Suctioning, trach and stomach care is essential to keep the airway free from secretions and then avoid infection. So we need to be careful with this stoma. Means of communication. Because of the loss of vocal cords, the ability to speak will be gone. So alternative forms of communication are necessary. Pen, pencil, paper, cell phone, communication board, anything that they can use to make their needs met. And then they need to know about chemotherapy and radiation side effects as it is necessary. And then this management is going to be facilitated through patient education. Patient education is so important in this aspect of their treatment plan. So post-laryngectomy, how do we know? How do we know that we've done a good job? Post-laryngectomy, patients can return to normal activities using alternative means of communication. This may take some practice. This may take some doing. But this is now going to become their normal, right? They have to find this way of communicating that is going to be normal for them. And they need to know that they are at a risk for recurrence if they continue to smoke and use alcohol. So if they go back to doing what they did before, the same thing is going to happen. If they change nothing, nothing will change. And they are going to come back to us with the same diagnosis. So radiation therapy, I want to talk about radiation therapy. Oral care is especially important in patients whose salivary glands have been affected. So a decrease in the production of saliva, which may be permanent, can occur, resulting in a permanent dry mouth. Permanent dry mouth. It is very, very uncomfortable. Changes in taste sensation, increased risk of dental cavities, and then oral infections can occur because the mouth is so dry. So patients will be instructed to increase oral intake of fluids, especially water, and then this will help to decrease their discomfort. It will help with their taste sensation, and it will lower their risk of infection. So, listen up, listen up, listen up. Encouraging the patient to suck on hard candy or chewing gum may be helpful. This will increase the production of saliva. Patients are instructed to use a soft bristle toothbrush and to brush and floss after each meal and at bedtime to cut down on irritation, to cut down on inflammation, and to lower the risk of infection. Patients are instructed to examine the oral cavity for signs of infection, ulcerations, or bleeding. So you will be instructing them after they brush to look for signs of infection, to check their gums for bleeding. Avoidance of foods that are spicy or acidic, and extremes in temperature are encouraged. Nothing really hot, nothing really cold, nothing spicy, and nothing acidic. Listen up and please take note. Chemotherapy. The nurse will monitor fluid and electrolyte balance. They are going to monitor weight, intake and output. They will encourage intake of fluids and small, frequent meals. Small, frequent meals. The nurse will also monitor the patient's white blood cell count for signs of neutropenia, and then the platelet counts for signs of thrombocytopenia. Because with neutropenia or with thrombocytopenia, if those numbers go too low, they will not be able to receive the chemotherapy. If the patient has a decrease in either count, the patient is placed on neutropenic precautions or on bleeding precautions. Patients are encouraged to avoid crowds and persons with infections and instructed to report increases in bruising, blood in the urine, or stool, or increased fatigue. Why? Because they're bleeding. Why? Because they have no platelets. So they need to be instructed to avoid crowds and people with infections, because Their immune system is going to be lowered, especially if their white blood cell count is a little on the lower side. They're going to be neutropenic, which puts them at risk for an infection that may take their life. So, this is not somebody who's going to well, nobody's going to a ball game or the movies now, but this is not someone that you would put in a crowded situation if COVID did not exist. Now that COVID exists, of course, everyone is on high alert. But if the patient notices that they have a bruise that they didn't have before, or that they're bumping themselves and they're bruising easier, if there is blood in the urine or blood in the stool, or if they are more tired than usual, they need to know that this is something they need to instruct the nurse or instruct the doctor. So how do we know? How do we know that we have taken a good care of this patient with laryngeal cancer? The treatment required chemotherapy, radiation, surgery, and the presence of METs will determine the outcome. So if we have been successful with chemotherapy, if we've been successful with radiation, or if we have been successful in using all three of these modalities, and there is no METs, then we have been successful. In patients where early detection has occurred, a complete recovery can be expected. Because we found it early, we can head it off at the pass. They may be in general good health overall, and the outcome is much better. If METS has occurred, the outcome is dependent upon the metastasis site and then how the patient responds to treatment. How are they responding to chemo? How are they responding to the radiation? Do they need surgery? Are they a candidate for surgery? And did they do well with the surgery? And then, are there any underlying conditions that is going to impede their recovery? So, laryngeal trauma. Laryngeal trauma. Laryngeal trauma is rare, very rare. So, laryngeal fracture occurs in approximately 1 patient per 14,000. Less than 1% of all blunt traumas. And this is partially due to the protected location of the larynx. It is a hard, bony structure of the cervical spine, posterior, and the mandible to a superior and interior position. So, the larynx is protected, right? It's very hard to get to. So, laryngeal trauma, although rare, but it can happen. It is seen in females because our necks are usually slimmer and usually longer. Males present with the highest percentage because of a greater participation in body contact sports such as fighting, football. How does this happen? Well, it can occur as a result of blunt or penetrating injuries, ingestion or inhalation of caustic agents to the neck, or pressure from prolonged endotracheal intubation. So, if somebody has been trached, or not trached, an ET tube, an endotracheal intubation, then yes, because it is a foreign body, it is going to cause trauma. So blunt trauma can occur as a result of assault, crash, injuries, falls, motor vehicle accidents, sports injuries, or strangulation. Penetrating injuries can occur from gunshots or stabbings. May be seen in the presence of cardiovascular, neurological, respiratory, or intestinal injuries. Patient outcomes are dependent upon early recognition and maintenance of an adequate airway. So we need to protect the airway, right? Always. So, clinical manifestations. What are we going to say? What are they going to say? Can they say? So, clinical manifestations will be dependent upon the extent of the injuries. Hoarseness, pain, that's stridor. Dyspnea, difficulty breathing. Dysphagia, difficulty swallowing. And then hemoptysis, which is bloody sputum. So these are all things that they may say, that you may notice, that you may see. The airway can become obstructed from edema or fracture of the laryngeal structure or hematoma development. So there might be some trauma, and we may not see the trauma from the outside. We may not see the trauma on the outside of the body. but there may be some bleeding on the inside of the body, and a hematoma might be forming that is going to obstruct this airway. Because of the potential of cervical spine injury, in addition to laryngeal trauma, stabilization of the cervical spine is vital. Now, listen up. Pay attention. Diagnostics will wait until the airway is protected and the cervical spine is stabilized. Do you understand? The first thing we need to do is protect the airway. You are looking to protect the airway. You need to make sure the cervical spine is stable. So these are the two things that you are going to do before you do anything else. This is not someone who has a motor vehicle accident and they come into the emergency room and everything is happening all at once and doctor is barking out all of these orders and you notice that they have a fractured femur. Your attention is please not going to go to the fractured femur. It is going to wait until the airway is protected and you are sure that it is patent and the cervical spine is stable. Then you can move on to anything else that is wrong with this patient. Surgical intervention, if necessary, will include evacuation of that hematoma, repair of lacerations, stabilization, and then repair of fractures. So, management. Diagnosis is completed by conducting a physical inspection of the neck for signs of swelling, discoloration, subcutaneous emphysema, tracheal deviation, and any open wounds. Diagnostic studies include a cervical CT, a fiber optic laryngoscopy, or a flexible bronchoscopy. Priority of care. Listen up. The priority of care is insurance and maintenance of that patent airway. Maintenance of the airway may include endotracheal intubation or, if doctor feels it's necessary, performing a tracheostomy. Priority of care is insurance and maintenance of a patent airway. Maintenance of the airway may include endotracheal intubation or a tracheostomy if it is necessary. So, symptoms are due to injury to the vocal cords and edema to the soft tissue of the neck. The patient may have a change in quality and character of the voice. They may be hoarse. They may have difficulty swallowing. They may have difficulty breathing. Discoloration and edema of the neck will increase the suspicion of this laryngeal trauma. Some nursing diagnoses. Listen up, listen up, listen up. Ineffective airway clearance related to edema. Please take note. Impaired comfort related to the surgery. Impaired swallowing related to the edema. Potential for impaired verbal communication related to the tracheostomy. But the number one nursing diagnosis right here is ineffective airway clearance related to edema. Please take note. So we are nurses and we assess and then we go back and reassess. So we are going to do a physical assessment of the neck and the upper airway. We will identify if they were at risk for laryngeal trauma, if there is discoloration, if their voice does not appear within the norm, if they have stridor, if they are using accessory muscles for breathing, if they are restless, indicating that they are hypoxic. Vital signs. Listen up, listen up, listen up. Increase in the respiratory and the heart rate, decreased oxygen saturation, and tachypnea will indicate respiratory distress. Please take note. Increase in the respiratory and the heart rate, decreased oxygen saturation, and tachypnea will indicate respiratory distress. Please take note. Nursing actions. We are going to have a tracheostomy insertion tray at the emergency department at the bedside. We are going to have it at the ready because the patient may have a sudden loss of the airway requiring an emergent tracheostomy. So this equipment needs to be at the bedside for doctor. Provide humidified air via a face mask or a face tent because this will help to decrease the airway edema. Keep the head of the bed elevated at 45 degrees or higher if they can tolerate it. Elevation of the head of the bed will assist in decreasing edema and maintaining a patent airway. Listen up, listen up, listen up. Aspiration precautions. This patient will maintain an MPO status to protect the airway in the presence of edema and or bleeding. Please take note. This patient will be on aspiration precautions and you will maintain an NPO status to protect that airway. Patient education. After all is said and done, you are going to teach the patient to report to the healthcare provider any symptoms and when to seek emergency medical care. Are they short of breath? Is there a change in their voice? Are they noticing something is discolored? Are they having difficulty swallowing? A compromise in airway patency can quickly progress to airway occlusion and death. So they need to know what to look for. They need to know what to report. Maintain voice rest. Limit talking to prevent an increase in the trauma in the larynx and to prevent further edema. So, how do we know? How do we know that we have done a good job in taking care of this patient? They understand that early recognition of airway compromise is key. And even for yourself, you need to be able to recognize early recognition of airway compromise. You are going to provide close monitoring of their respiratory rate, their respiratory effort, their breath sounds, and their oxygenation status. Keep the head of the bed elevated and provide adequate humidification, and this will help in decreasing edema to the area. Encourage the patient to observe voice rest, minimizing irritation, and to avoid that airway compromise. So the tracheostomy, we've already talked about this, right? We've talked about it in respiratory skills. So if a patient requires mechanical ventilation for longer than 7 to 14 days, a tracheostomy is usually performed to prevent laryngeal and upper airway damage that is associated with prolonged use of an ET tube. A tracheostomy is indicated to provide a stable airway. It's a stable airway in patients who require long-term ventilator support to allow us access to the lower airway for suctioning and to relieve upper airway obstructions. The tracheostomy will replace the ET tube and provide the patient improved comfort and then increased safety. And so here, this should be the same picture that you saw for the trach. So here, on the left, you can see the endotracheal tube, and that is the tube that is going in through the oral cavity, through the mouth. And you can see how it is bypassing the epiglottis, the glottis, the trachea, and then the esophagus, right? You can see all that. And then on the right-hand side, as you're looking at the slide, you can see the tracheostomy. And you can see that the epiglottis and the vocal cords and the trachea are above the tracheostomy site. Okay? So advantages include decreasing airway resistance, allowing air to enter directly into the trachea and the lungs, allowing for decreased workload of breathing compared to air traveling from the upper airways to the lower airways. Remember, we talked about this at the very, very beginning of the PowerPoint. This will also allow for improved oral care over the ET tube, which goes into the oral cavity into the mouth. Other advantages include improved airway security due to the fact that the ET tube is not as secure. The trach we know is going to be secure. Improved access for removal of secretions, and then improved patient comfort. So the tracheostomy will allow the oral cavity to be free of tubes, making it easier to read lips, and in time patients may be able to eat. Disadvantages are the inability to communicate verbally, and this is similar to the patient with an ET tube. So permanent or temporary, there are a number of different types and sizes. Type and size depends on the patient's size and the rationale. How big is the patient? How big is the patient's neck? And most consist of an outer cannula, the neck plate, the inner cannula, and then the obturator. And again, these are the parts of the tracheostomy tube: the inflated cuff, the inner cannula, and then the obturator. So, the outer cannula is the tube that holds the tracheostomy open. The neck plate extends from the sides of the outer tube. Listen up, listen up, listen up. It is the neck plate that will hold the outer tube in place. Okay, so the outer cannula is what's holding the tracheostomy open, but it is the neck plate that is going to hold that outer tube in place. There are holes in the neck plate will attach to the Velcro strap around the neck. Please take note. Please take note. The inner cannula will lock inside of the outer cannula. The obturator is going to be used to insert the tracheostomy tube. Most tracheostomy tubes are made of metal or plastic. I have not seen a metal one in quite some time. Most are plastic now with disposable inner cannulas. So you may have an inner cannula that can be removed for cleaning, or a disposable inner cannula. So if that is the case, when you're doing your trach care, you're going to take out the inner cannula. You're going to throw it away because it's disposable. You're going to do your trach care, and then when you're done, before you leave the patient, you're going to make sure that he's stable, and you're going to insert a new, fresh inner cannula. And then there are also cuffed and uncuffed tubes. So listen up, listen up, listen up. A cuffed tube is used for the patient who needs continuous mechanical ventilation, or for a patient who is at risk for aspiration. Please take note, please. A cuffed tube is used for the patient who needs continuous mechanical ventilation, or a patient who is at risk for aspiration. Now, an uncuffed tube is used for patients who are ready for decannulation. This means that doctor feels that they are ready. We are looking at them, we are assessing them to make sure that we can safely remove this tracheostomy tube and they will be able to breathe on their own. They are not receiving mechanical ventilation. Listen up, listen up, listen up. The fenestrated tube is similar to the cuff tube, with the exception that this tube has small openings in the cuff that will allow the patient to speak. Please take note. The fenestrated tube is similar to the cuff tube, with the exception that this tube has small openings above the cuff that will allow the patient to speak. The fenestrated tube has a removable inner cannula and a plastic plug. If the inner cannula is removed and the cup is deflated and the plastic plug in place, the patient is able to speak and breathe through the natural airways. So this is something that doctor will use when we are getting ready for the decannulation process. This allows the healthcare provider to assess the patient's ability to breathe using the oral nasal route in preparing for possible decannulation.